participant. Hello.
Mike. Hello,
Yes, ma'am.
can you see me?
Yes, ma'am. You are visible.
And what about my presentation?
Visible for all the participants.
Actually, yes, ma'am. Now,
Yeah, yeah. Now it's visible. Now it's
The
visible, ma'am.
presentation. That's my
yes,
first
ma'am.
slide.
1 second, ma'am. 1 second. So, dear all participants, we are now moving to our second technical session of third day, which will be conducted by Dr. Archana Nikose, ma'am. Dr. Dr. Archana Nikose, ma'am, is an MBBS, MS in ophthalm, and MCS in ophthalm. She is ophthalmic surgeon with 27 years of experience across 4 countries, including 2 years in NHS, with a proven ability to improve patient care and provide them with clinical and emotional support of the highest standard during the diagnosis, treatment, and recovery. She is currently working as a MCH training, Brinting, Brintington Vegan, and Lee NCH and HS Trust Vegan. She independently performed over 50 phacoemulsification surgeries and more than 500 intravitreal injections. She had worked as a former assistant professor NKP Salva Institute of Medical Sciences.
It's
She is
associate.
also is a specialist in yes, ma'am, associate professor.
It's okay, fine. Yeah.
Uh, she is a specialist in ophthalmology, New National Medical Center at Abu Dhabi. Her research experiences include as an academic editor of Asian Journal of Research and reports in ophthalmology. She is a reviewer of ophthalmology research. She is also a reviewer of seminar in ophthalmology in a journal. She attended almost 100 conferences and webinars CMEs. Her publications are around 100 plus.
It's okay,
So
Sarah. We can
now
start. Yeah.
So now I
Carry on.
request Dr. Archana Nikoti ma'am to share their valuable insights with us. I am going to hand over the session to her.
Thank you, Sarah. Thank you very much. And I'll like to thank Dheeraj sir for giving me this opportunity. So, can you see my screen, Sarah?
Yes, ma'am. Yes, ma'am.
Yeah. So, my topic is machine learning and ophthalmic therapeutics. Is my sound clear, Sarah?
Yes, ma'am. You're audible. The screen is also visible.
Okay. So, we go ahead. Now, we will just talk about the topic first, right? So, it's machines or use of machines in ophthalmic therapeutics. I can see that your session is for almost 6 days, and I think many speakers must have spoke regarding the machines in medical profession. So we use machines like for every small thing in the medical profession, but most of the speakers must have spoke regarding the investigative part of the machines in medical profession. I'm going to speak regarding the therapeutics. Here, therapeutics means I'm going to use or going to speak about the usage of machines in treatment of ophthalmological diseases, right? So that is the meaning of my topic, ML in ophthalmic therapeutics. Now, it's really difficult because I cannot see the audience, but if any questions, just you can stop me and I will answer them first. Okay, to start with, now my first question to Dheeraj sir was, Why medical topic in a engineering based college, and why do you want to use my speech or my expertise in your field? So the answer was, he said that you have a lot of postgraduate students attending today and researchers, and my speech may help in giving some ideas to the listening audience, right? So going on with the first, as I said, medical machines in ophthalmic therapeutics. Now, I'll start with my branch. You must have known all branches in medical field, but like Saira was not able to pronounce my ophthalmology, similarly, very few must be knowing the details about ophthalmology. Of course, everybody knows it's related to the eyes, and our branch is basically a combination of medical and surgical things. That is, we use both the practices, medical as well as surgical, and thus it makes ophthalmology a comprehensive field of healthcare. Now, there are many eye-related issues we face. I'm just going to discuss some of the very few and the very common diseases in which machines is going to be used. So the commonest is cataract, which is like almost 50% or 40%, 40 to 50% individuals will get after the age of 50. So there is a very high number of disease of this occurrence of cataract. Second commonest is glaucoma and some of the retinal diseases, which we are going to discuss. The vision improvement. Now, the primary goal in ophthalmology is to give clear vision to whomever comes to us or the patients who attend the eye clinic. Now, as you can see this photograph, this is the eye which is seen in from front, and the right side photographs are basically the retinal photos. If you want to know just some structures, I'll name before we go ahead, so that when I speak, you have an idea what I'm talking about. Again, I'm just repeating. Any questions, just please stop me wherever you want. Now, to the left-hand side, you can see a photograph of eye. Now, the eyeball, you can see between the two lids, there is an eyeball. In the eyeball, we have that round part, transparent, which is called as the cornea. And the white part is the sclera. So it's like a ball. Eyeball is just literally like a ball. Now, here you can see the pupil, which is big. Pupil is the window through which we can see the back of the eye, and the images are formed onto the retina. The white part is the cataract, which I am going to talk for mostly half of my session will be on cataract, because this is one of the commonest ophthalmic disease we come across, right? The second photograph on the right side is, nowadays diabetes is one of the commonest disease which is seen in India, rather in all part of the world, in UK also, but in India also is very common, and that is because of our lifestyle, our eating habits, and whatever it is. So this is the retina, which is the back of the eye, which is going to get affected because of diabetes, right? And these are two diseases I have named. One is the non-proliferative and second is the proliferative diabetic retinopathy. Now, and the third commonest condition which I am going to speak is glaucoma. Now, the left side of the eye is showing the glaucoma, and right side. Okay, so there was some disturbance in the background. Maybe somebody's mic is on. Right. So any questions till now? So this is the third commonest disease we are going to speak. So the first is cataract, diabetic retinopathy, and glaucoma. There we have many diseases, but these three are the commonest which we come across. And obviously, these three may have some potential for research for you people. Now, as I said, I started my career in 1991, and 30 years back, the cataract surgery theater that is the operating theater I'm talking about. It just had a table, a simple light, and the bare hands of the surgeon. Mostly there used to be no gloves also. So these are the only three things we had in the theaters 30 years back. The operating theater, I mean, when I'm talking about a theater, right? Now, I'll show you the today's operating theater. This is the today's operating theater. You can see machines everywhere. So that's why I'm going to speak about machines which are used in ophthalmic therapeutics. And the first and foremost is the operating microscope. Now, you all can imagine that eyeball is a very small thing, a small structure. And when we are going ahead with any surgical procedure, we want magnification, binocularity. That is very important. When I say binocularity means when both eyes are working together. Now, imagine if you're just seeing, all of you, if you're seeing just in front of a switchboard, you just close one eye and see with that, the switchboard. Then close another eye and see again with one eye. If you open the eyes, you can see the depth perception. That is, you get a stereopsis. You can see the side width, depth of the any object in front of you if both eyes are open. If only one eye is open, you will not get that depth perception. And hence, binocularity is very important when we are operating on a microscope, under the microscope for small surgeries. And of course, magnification, you all know. Now, why microscope were integrated in the ophthalmic surgery? Yes, any questions? I heard something. Uh, okay. So integration of microscope in surgery. Now, as already told, it enhances the visualization. I'm going to see a magnified image, and our microscopes give us a magnification of up to 40 times. So a small eyeball, we can see it as large as 40 times, which increases the surgical success, improves the surgical outcome, and gives better results. Of course, any complications that can be managed very well with a microscope. And so microscope is one of the machines which has revolutionized the cataract surgery. Now, the second commonest important machine is the minimal invasive procedures. Now, before, you can see the left-hand photograph here. This was the eyeball, and we used to give almost 14 to 15 millimeter incision to remove the cataract. This is the cataract. You can see the lens, it was removed completely. Now, that 15 millimeter incision has become so small. It is now 2.8 to 3 millimeters of incision because of a machine again, and that is called as the phacoemulsification. Right? So it's a phaco machine or the phacoemulsification machine, which has revolutionized the cataract surgery by incision size and the improvement of the vision to the patients. Now, this is the phaco machine, the latest phaco machine, again, invented, and the biggest revolution on cataract surgery. I will just tell you in details about this machine. Uh, it is basic. This is a machine. It's something like driving a car. You have to use your feet. You have to use your hands, of course, both hands, and of course both eyes. So the both eyes in the microscope. This is the foot switch. We require both feet to operate the machine, and of course both hands to hold the phaco probe. These are some other parts which I'm just going to tell you in details. So, phacoemulsification is one of the greatest invention in last 30 decades. And that's because the incision size has reduced, the cataract surgery has become minimally invasive, and my patient can go back to work the next day. He can get up from the table and go back to work from the next day. So that is the faster recovery, which is very important. And of course, a spectacle-free vision after the cataract surgery. Now, as this all talks are basically to give your PG students some ideas, but the phacoemulsification machine was invented in 1963, again by an ophthalmologist. Charles Kellman was an ophthalmologist. So he started with a tip. It was a vibrating ultrasonic tip which fragmented the cataract, and then it was aspirated from the bag. So as I'm telling you again, the 15 millimeter incision has reduced to 3 millimeters. That's too much of a improvement. Now, as you can see, this phacoemulsification machine, it's an ultrasonic device. You can see here, this is the phacoemulsification probe. We require both hands. One hand we use the probe, another hand we have another instrument here. It removes the cloudy lens, which is called as cataract, into the eye, from the eye by emulsifying it, and then it is aspirated and irrigated. Now, some physics part of it, the phacoemulsification handpiece, it has a tip which vibrates longitudinally at a frequency of 27 to 60 kilohertz. And the handpiece has piezoelectric crystals, which and some magnetorestrictive materials to generate this vibration. Now, this part is something not related to the medical field, maybe understood by you better. All right. So this is the cut section of the eyeball. Can you see? This is, we have cut for, this is a small phaco probe which goes into the eye. This is the lens or the cataract, which is, there is a tip which goes in front and back, vibrating ultrasonic tip, which will remove this cataract. Then we will aspirate it. So that is the surgery. Seems very simple when shown with, but it has a very long learning curve. Now, these are the parts of the machine which it has an infusion system. That is the irrigated bottle. That's the bottle height, which has a fluid. Then this is the pump, which aspirates. This is the ultrasonic handpiece, and this is the eyeball where this tip will go in. Okay. So it has one irrigation port, which will send the fluid into the eyeball. This has an aspiration port, which will aspirate the emulsified lens, and it will be collected in a bag. Now, the bottle height is the most important part because it is almost up to 3 feet or more, and the water goes into the eye at a particular speed from a height, which helps to maintain the intraocular pressure when we are doing the surgery. It is difficult to understand because when we started phaco, it was difficult to understand, and for you people, obviously, it is something out of your curriculum. So you can just write your questions and we'll discuss it later, right? Now, again, a cut section of the eyeball. This is my phaco probe. It's gone in. It will remove the nucleus. Now, when I say nucleus, the lens which I showed you in the starting, it has a capsule and it has a nucleus and a cortex. So we are going to remove the lens. When we started cataract surgery 30 years back, I showed you the photo. We used to remove whole of the lens together from a 15 millimeter large incision. Now we break it inside the eye and remove step by step. So first remove the anterior capsule, then remove the nucleus, and then the cortex. So the cortex is aspirated by the irrigation and aspiration, which is done as the second step of the surgery. It is difficult to understand for you, but just write your questions. I'll answer you later. Now, Once you remove that cataract, do you know the refractive power of the cataract or the lens inside the eye? Can anybody guess how much it is? It's a strong convex lens. The lens which we have inside is a strong convex lens of plus 20 diopters. Today, we cannot make plus 20 diopters lens still in the form of glasses, but yes, we can make it in the form of intraocular lens. Now, when you remove plus 20 lens from the eye, obviously you have to replace it. Otherwise, the person will not see anything. As I said, you want a spectacle-free vision. So for that, you have to put a lens, and you can see this. This is from the same small opening. We are going to put a foldable lens inside, and this lens will give or act as a natural lens. Of course, it can never be natural, but almost like a natural lens. Now, the phaco machine is of two types. It has a peristaltic system, and second is the venturi system. These are again the aspiration techniques, what the machine uses. These are the two different type of aspiration techniques which the machine is going to use. One is the peristaltic, and second is the venturi system. Again, maybe you people, if you have learned in physics, you may know about this. For us ophthalmologists, it is something difficult to understand. We depend on the machine engineer who comes and adjusts this for us. So not my cup of tea. Now, even with the phacoemulsification, we were not satisfied, and so we invented, not we, but it was some engineers invented a laser that is called as a femtosecond laser, which is used as another advanced technique for cataract surgery. So I showed you, this is the eyeball which is cut in the section. This is the lens which we want to remove with a small opening. Now, I told you about the phacoemulsification surgery. This is the femtosecond laser. Now, femtosecond laser, it will not do the complete surgery. It will do only part of the cataract surgery. Like it will do a opening. This is the opening. This is the laser light. It will do an opening in the anterior lens capsule, and then it will break the nucleus. You can see this nucleus is broken into few pieces, and then we go back to phacoemulsification. So femtosecond laser will not do the surgery completely. It will do only half of the surgery. So not very happy with this, but laser, I'm going to talk with you because lasers is again a revolution in the machines for ophthalmic treatment. Now, as I said, we are going to put an intraocular lens, right? So the intraocular lens also has a story. They say that during the Second World War, that was in 1940s, there was some airstrike, and one of the pilots had a crash with a small glass particle into his eye. He went to ophthalmologist. That war was around 1944, maybe. The eyepiece remained in his eye, and he was seen by ophthalmologist, that is Mr. Harold Ridley, in around 1950. And seeing that the piece stayed in the eye for 4 long years without causing any reaction, without causing any inflammation, without causing any infection, gave the idea to Harold Ridley to invent an intraocular lens. So again, it's an ophthalmologist who invented this lens, not an engineer. I'm not discouraging you, but just a story to tell, right? So it was 1950 when Mr. Harold Ridley introduced the intraocular lens. This was the first lens. Now it has been almost 75 years since the lens has been invented, but we in India got the lenses around 1997, 1998, right? So, but now we are almost at par with all the Western countries, US and UK, in having all the different type of lenses. What they have, we have everything. Yes, it started late. Right. So this was the first lens which was invented by Mr. Harold Ridley. It was exactly like the shape of the lens, what we had, natural lens. But then it had some disadvantages, and the new lens came up, and this is the new lens which we have today, right? This is the center part, and these two haptics which we have to fix the lens properly into the eye. Just a short different type of IOLs. Like if you go to ophthalmologist, they will be asking you what type of IOL you intraocular lens you want, and these are the various type of lenses which we have nowadays: the monofocal lenses, multifocal lenses, bifocal lenses, trifocal lenses, and the lenses can be placed in different part of the eye. It can be in the anterior chamber. It can, again, the terminologies may be really new for you, but there are various places in the eyeball where the lens can be placed. Okay, so it can be in the anterior chamber, can be in the posterior chamber, can be on the iris. So just in a short about the lenses. Then this is all about the cataract surgery, the invention of the phacoemulsification, and the different type of lenses. Yes, so I'll just like to stop for a minute. Any questions for phaco, I'll take, and then I'll switch on to the next part of my talk. Yes, Sarah, anybody has any questions for my phacoemulsification?
Any participants want to ask any queries? Our expert is here to answer your questions. You can ask your questions by opening your mic, or you can also write your question in chat box.
Yeah, but Sarah, if they write it, you have to read for me because I cannot see the chat box.
Okay, ma'am.
Okay, I think it's time for sleep in India. It's almost 8 o'clock. So nobody is very attentive.
Yes, ma'am. It's almost 7. Exact time is 7:46 in India.
Yeah,
So,
so 8 o'clock is the time to
but our
relax.
participants
Nobody
are
wants to
really
listen.
active.
Okay. Okay. So as I said, it is something very different from what you people are practicing. All terminologies are different. The machine names are different. Everything is new for you. So I can understand it's difficult to understand. But any simple basic questions also I don't mind. Okay. So you can just write it for the end of the talk. Now, should we go ahead, Sarah?
Yes, ma'am.
Okay, so coming to the next part of my talk is the lasers. Now, lasers is again one of the most important invention which helped the ophthalmic field in many ways. I'll just tell you how. Now, uh, light, as you people all know, is an electromagnetic wave emitting radiant energy in tiny packages called as the quanta or the photon. This is something which you people may understand better. Each photon has a characteristic frequency. Its energy is proportional to its frequency, right? So the three basic ways of photons and atoms to interact is the absorption and spontaneous emission. Like the laser light has certain characteristics. So one is, as I said, absorption, spontaneous emission, and stimulated emission, isn't it? Right. So the laser is light amplification of stimulated emission of rays is the full form of laser. L is light, A is absorption, S is spontaneous, E is emission of rays. So that is the full form of laser, which means that we are going to use this light energy in form of different machines for treating ophthalmic conditions. Now, so the absorption, you understand, spontaneous emission of energy, you understand, it is this light is passed through certain things, it's triggered, stimulated, and then it's emitted again, and that is called a stimulated emission. So same thing again, it's absorption, spontaneous emission, and stimulated emission. Now, this is absorption. These three principles of the laser light, we are going to use them in treating some of the eye conditions. So again, the basic, that is absorption. light is thrown, it's absorbed in in our tissues. Then when this is a light ray, there is a spontaneous emission through the machine, and this is a stimulated emission. Now, what is a laser? I has already told you the full form of laser. It's a stimulated emission of light rays. The light is monochromatic here. Our ordinary light is polychromatic. A laser light is highly energized. The simple light is poorly. The quality of laser light goes into parallel rays. The parallelism is very important. We don't want laser light to get diverged here and there. And it can be sharply focused on the exact point where we want that laser light to work. These are the basics. I'm going to tell you how it works in eye. So you know the light has various wavelengths, and the wavelength which we use for lasers these wavelengths. Like 488 is the wavelength for the argon blue laser. If the wavelength goes to 514 nanometers, then we have the argon green laser. 532 is neodymium YAG laser. Then this is the yellow to red laser. These are all different wavelength laser lights which we use for treating ophthalmic diseases. And I will tell you how these laser lights, these are the name of the lasers, and we're going to use it in different machines and diseases. Now, whenever the laser light comes on and hits a tissue in the eye, the laser, we have various wavelengths, as I showed you just now. These are the various wavelengths which we use. The spot size is very accurate, the power which the laser light is going to give, and the exposure time. These four things are very important when this laser light is thrown into the eye, and what is desired from this laser light, we are going to achieve that. I will tell you how. This is just the basics. Now, again, the tissue variable. As I said, the eyeball has various layers and it has various pigments. You know, we all are brown eyes people. Like we have a particular type of a pigment in the iris which makes our eyes brown. The part in of the country which of the world which I am working here in UK, here the pigment almost 90% people have blue and green eyes. Now, blue and green eyes, again, it depends on this pigment which is there in the iris, right? So all these, the tissues, the eyeball tissue has these three characteristics. It has a transparency. Transparency, as you can see the cornea, it is a transparent structure. The central round part is the cornea, which is transparent, through which the laser light will enter. Then we have a pigment, which I told you. The iris has a pigment, the retina also has a pigment. So this pigment helps in absorption of this laser light. And obviously, every body parts has a particular water content. This again is going to help us to absorb that laser light and change accordingly what we want. I don't know whether I'm making myself clear, but I'll just like to repeat here something. The tissue, the eyeball tissues, we have transparency, pigment, and water content. So these three things help us to absorb this light and treat certain diseases. That's the very basic sentence I can make. Now, as I told you the laser light and the tissues what we have, right? So the laser light, when it passes and reaches a tissue means the part of the eyeball or any cell of the eyeball or various layer of the eye, that is called as the tissue. Now, as soon as the laser reaches the tissue, it has three effects. One is the thermal effect, second is the photochemical effect, and third will be the ionizing effect. Now, the thermal effect is most commonly used, and even the photochemical. Now you can see this photocoagulation. Photocoagulation is, photo is light, coagulation is coagulation. You all know the protein is denaturated and we call that process as coagulation. So this laser light enters into the eyeball. This is the eyeball tissue where, depending on the wavelength energy of the laser light, it will have different effects. It can have a thermal effect, it can have a photochemical effect, it can have a ionizing effect. As I said, we desire mostly the thermal and the photochemical effect. And I'll show you what is photocoagulation, what is photo disruption, what is photo vaporization. Again, these terms are self-explanatory. Photo is light, coagulation you know, disruption you know, vaporization you know. So light giving rise to these structures into the tissue of the eyeball, which may help to treat certain eye diseases. Now, the first which we are going to use is the photocoagulation, right? So photocoagulation, the laser light goes on from the machine. This is the laser beam. It goes on to the target tissue. Here, my target tissue is the retina. Can you see this? This is the retina. So the laser light is gone through from the cornea, from the pupil, and gone back to the retina. Now, why it went to the cornea? Because, as I said, cornea is transparent. It went to the lens because lens is also transparent here. We don't have cataract. We have a clear lens like you have now, all young people there. So the lens is clear, the cornea is clear, and this is the retina where the laser light reaches. That is the exact site where we want this laser to act. Now, so this is a laser light. The target tissue is retina. This laser light will generate heat here because it has been, the purpose of this light is to give its thermal effect, that is the heating effect. Now the heating effect on the retina, it will denature the proteins there because of the heat. That is called as photocoagulation, and it will generate almost 10 to 20 times of, increase the temperature from 10 to 20 times and cause a burn. Obviously, when heat is there, there will be a burn, and the burn here, we desire a burn on the retina, right? So you can just ask me the question later on why I desire a burn on my retina or the retina, because it's a diabetic retinopathy where some of the blood vessels have become abnormal. They are not normal now, blood vessels. So we don't want these blood vessels to damage the eye, and we want to damage them. That's why we do the photocoagulation of these abnormal blood vessels, which is called as neovascularization. So you all know we have normal blood vessels. Normal blood vessels do their normal job. There's nothing wrong in that. We want them there. But what we want to damage is the abnormal blood vessels, which are not going to help the eye in vision. I hope I'm clear here. Again, just write a question there. You can ask any silly question. I know, because you cannot understand most of the terminologies. I don't mind even the most silly question, right? Then, coming to the first, we discussed photocoagulation. That is light passing onto the retina, converting into heat, and causing photocoagulation of a particular area on the retina. Now, the second property of the laser, which we are going to use, is the photo disruption. Now, photo disruption is light causing a mechanical effect, giving rise to some acoustic shock waves and causing a damage, a tissue damage. We want this tissue damage. We don't want to damage a normal tissue, but we want to damage the abnormal tissue which is growing on there. And can you see this? Again, this is the blue iris, which I'm talking about. This is the cornea, and this is the cut section of the eyeball. You can see only the half eyeball. So the laser light enters, again, transparent cornea. Here, this is the lens. It's a artificial lens here. And sometimes behind the artificial lens, you can develop certain opacification, like the lens reacts with the body, and it will give rise to opacities behind the lens, which we want to remove. Now, we cannot operate again and again. So the laser was invented, and we just took that part of laser, which is going to disrupt or cause the damage of the tissue, which is we don't want. There is something which has developed there which we don't want. And this laser effect, which we are going to use, is a photo disruption part of the laser. Again, I'm really not sure how much you're understanding, but just write a question. I'm going to answer all of your queries, even the most silly ones. Then, coming to the photo vaporization. We spoke about the laser light helping in photocoagulation. Then, second was photo disruption. Third is photo vaporization. Now, vaporization is, this technique is used in femtosecond laser. Did I show you something before? The femtosecond laser photos? This, right? So this is the photo vaporization technique. The laser light, can you see this? This is the laser light. It goes on through the transparent cornea on the lens, and can you see it creates a incision here. So it evaporates that area from here, and that is photo vaporization. So it's a type of laser which is going to be used, or which is being used in femtosecond laser. Right, so coming back to we finished the thermal effect, photocoagulation. This is the photo disruption. This is the photo vaporization used in femtosecond laser, where the light passes, the laser light goes onto the eye, onto the lens surface. There it increases temperature, the basic temperature increased by 60 to 100 degrees, which will absorb the commonly used carbon dioxide, will absorb the water from that cells, and that heat will cause cauterization and a clear incision, which is used in, which is the main principle of femtosecond laser. Now, the photochemical effect, this most of you must have heard, that we are doing some surgery, some laser surgery is done to remove the spectacles, right? Most of you must have gone to ask about it. So this again is a type of laser. This laser has, this is called as the photochemical effect, and it's called as photoablation. That is, with the light, ablation is removal. We are going to remove or a part of the tissue or very minimal tissue to give rise to a photorefractive keratectomy, and that is called as the excimer laser. I'll show you this in a detailed photograph where you will understand what exactly I mean by this. Now, this is radiation, PDT, which is usually done to remove the ocular tumors. You know, tumors are some types of cancers in the eye, and which can be removed, or which can be just the laser light goes in, causes a photoradiation effect, and removes or burns that ocular tumor. Then coming back to the different types of lasers, this is the first type, which is the ND-YAG laser. Now, this is a short form. ND is neodymium. YAG is yttrium aluminium garnet. So that yttrium is, Y is silent, so you can just trium aluminium garnet is the name of that laser, ND-YAG. So it is a crystal which is used for giving a laser medium for solid state lasers. Again, this laser light has a wavelength of 1064. It is infrared light, which goes, which was this? It was photo disruption laser, which is going to remove the posterior capsular opacifications. This is going to remove the posterior capsular opacification, which I spoke just now. When we remove the cataract, we put a lens. Behind the lens, there can develop some opacification again. You cannot do surgeries again and again. And then because of this laser, we can just remove that opacification which has developed behind the lens. So this is rather, nowadays, almost 60% of individuals who had the cataract surgery require this procedure. I don't know what we used to do 30 years back, but now this is like, in my clinic here, I almost do 15 lasers in a week. So that common it has become, and that commonly we use it. So that is a YAG laser posterior capsular opacification is removed, or we call it as a capsulotomy. The second most important use of this laser, ND-YAG laser, neodymium tritium aluminium garnet, is the full form of this laser, is used for iridotomies for the angle closure glaucoma. Now, iridotomy, I just now said that we have the color of our eye is because of the iris. We have brown eyes, here people have blue and green eyes. So that is that round color is called as the iris, which the laser can make a small hole in this, and this is called as peripheral iridotomy. Recently, one more modification of this ND-YAG laser is the frequency double ND-YAG laser, which can do many things. That is, it can do even the photocoagulation. Basically, ND-YAG was going to do the photo disruption only. Photo, light, disruption, photo disruption. But this has been modified into frequency double, and now it can do even the photocoagulation, which I showed you on the first slide. Okay. This is the excimer laser. This was the laser which I was going to tell you in detail. So this is the photochemical laser or the photoablation called as the excimer laser, which may interest you people because maybe at least 10% of you have gone to the ophthalmologist to remove your glasses. You don't want your glasses. You just want to do a surgery that is called as the excimer laser surgery to remove the glasses. Now, what are you going to do with this? So this is the ultraviolet laser. Can you see this? This is our eyeball in cut section. This is the cornea. This is the iris. And this is the lens. Right? So, as I said, the cornea is a clear, transparent, convex lens. Do you know the dioptric power of the cornea? Can anybody tell me the dioptric power of cornea? Dioptric power, it's a convex lens. So it's a strong plus lens. So physics. Okay, so it is 40 diopters, 40. Again, it is not possible at present for human beings to create a spectacle of 40 diopter lens. The maximum lens an optician can make in the form of glasses is only 10 to 12 diopters. So a 40 diopter lens is a thing which a human being cannot make till now. And so, as I said, the dioptric power of the cornea is 40 diopters, and the lens was told before 20. So the total refractive power of the eyeball is 60 diopters plus 60. Right? Now, some changes in this plus 60 will give you rise to your spectacle. So it can be because of the cornea, it can be because of the lens, it can be because of the size of the eyeball. So here we are going to use this excimer laser. So this is the cornea, this is the laser machine. This laser machine will remove, it will ablate some of the tissue from the cornea and will correct your refractive error. That is, remove your glasses. So this is one of the commonest use you must have heard, excimer laser surgery for removing of glasses. This is called as the LASIK surgery. So you can see this is the eyeball. I don't know whether the picture is clear for you. This is the microkeratome. Keratome is this. Can you see this is a cornea? We have removed a small layer of the cornea. The cornea is thick. We have removed a small layer from there. Then the laser light goes on to the cornea, and then we replace back this tissue, and that is the surgery done. It just takes 10 minutes. So everything is done by the machine. Nothing, the human being just has to enter certain readings and certain findings. Rest, everything done by the laser machine. The microkeratome is a machine. Everything is done by the machines. Now, laser in glaucoma. So we spoke about laser in cataract. We spoke about laser in treating or removing the glasses. Now, laser in glaucoma. These are the two procedures by which the laser can help in treatment of glaucoma. So one is laser iridotomy. Iris, again, it's this part which is brown, blue, green. We are going to make a small opening there by the laser light for helping in treatment of glaucoma. The second is laser trabeculoplasty. This is again a part of glaucoma surgery done to treat glaucoma. Okay, so I know these terms are totally new for you. It is difficult to understand, but just scribble a small question there onto your letter pad, and you are going to ask me at the end. I want one question from all of the participants. Yes. Now, this is which I told you. It's the posterior capsulotomy, which I already showed. Which laser it was? ND-YAG laser. That is neodymium, yttrium, aluminium, garnet. That is the full form of YAG laser. So this is a laser beam. I told you that this is a lens which we had. So this person has underwent a cataract surgery 5 years back. So the vision was very good. Now the patient came and that he said he's not happy with it because the vision is now not as good as it was when we did the surgery. So that is because this is the lens. Behind this lens, some opacification has developed. So we take the patient onto the laser machine. It's just sitting down. The patient is sitting down. It is just 1 minute procedure. The laser light goes into the eye and it doesn't damage the lens. It goes exactly. That is the characteristic of laser light. It will hit that area where you want. It will give that much energy, what you want, not a millivolt extra or not less. And here it is going to remove that opacification. So it is photo disruption. Laser light causing a desired disruption of the opacified capsule. This is again a cut section of the eyeball. This is the cornea. This is the pupil. This is the lens which we have put, and this is the posterior capsule which we want to disrupt because it has opacified and hence it is reducing the vision now. So we have to clear that. That is done by a laser. Now, the photocoagulation, which is the most important, this is the retina. Can you see this? This is the right eye, this is the left eye, this is the optic disc, this is the whole of the retina, and this is the laser light. So now, why you want to give this burns onto the cornea? I said photocoagulation. Light is going to coagulate the protein here. Again, I told you before, because these are abnormal blood vessels here on the retina, which develop in diabetic retinopathy. These abnormal blood vessels, they leak, they are leaking. They are not like good pipes. They leak water. So you don't like, nobody likes leaking pipes. Nobody like leaking blood vessels. So these leaking blood vessels are damaged by the laser light, which we call it as photocoagulation, right? So the photocoagulation, these are the white spots. That is the laser light when thrown on the retina. In this particular area, there were some abnormal blood vessels which were leaking and reducing the vision. So the laser has photocoagulated that area, and that vessels which were leaking, which were not good, have been damaged there. So the normal blood vessels, which these are the normal blood vessels, then they can continue their work. Now, all the lasers, what we do, or the phacoemulsification, what we do, all have his pros and cons, positive and negative points. So obviously, there are some hazards of the lasers also. So the acute exposure of the laser eye to the laser can cause corneal and retinal burns. If you are not focusing that laser beam on the exact spot where you want, you are going to cause unnecessary damage to the various ocular structures. So the exact focusing is very important to reduce the damage to the eye. Okay, then the laser light, the chronic exposure to excessive levels can cause corneal and lenticular opacities. Again, some of the complications of lasers. The laser light in the visible to the near infrared spectrum can cause damage to the retina, resulting in scotomas or blind spot. Again, the laser light, as I told, is going on to fall on the retina. On the retina, it is going to damage the tissues where we want that tissue to damage. But here, you can see this. This is the most important structure of the eye, that is called as the macula. And we are very close here. If this burn comes on to here, then the vision is gone, because that is a damage then. So here we want it because we want to destroy the abnormal structures. But if this light comes on to the normal structure and it by mistake or by not focusing properly, if you damage this structure, then your vision is gone. So it is very important to focus the laser at a proper place before sending it or before treating that. And that is one of the most important retinal hazard which can happen in that area. So the laser light, as this is the spectrum where the laser light is going to thrown onto the cornea or onto the lens. So that's it. You can, yes, Saira, that's all about my talk.
I request all the participants who have any queries can ask to our expert.
Everybody is, I think, sleeping already, sleeping mode. This is scaring the.
Okay, now we are getting replies from participants. But
Yeah.
every any participants want have any type of query, even you have any basic query related to medical field or the terms which ma'am uses, you can ask about it. Our expert will answer that. So I request all the participants make this session interactive.
Welcome, Mr. Thackeray. Okay. So I'll just finish the talk then, Sarah. We don't have any questions. I can see that. Right. So is Dheeraj sir there? Any idea, Sarah? No.
No, ma'am. Actually, Dheeraj sir is not there today.
Okay.
He is not
Okay.
well today.
Okay. Okay. So do you know that basically the main idea for this talk was Dheeraj sir had started his some research on bionic eyes? Do anybody know about his research?
No, ma'am. Actually, I don't have any idea related to
Okay.
his research
Okay.
or.
Okay. So around, I think the bionic eye. I'll just tell you something about the bionic eye. If that is one of the most desired or maybe the most prospective trials which are going on, because making an artificial eye, I think that is one of the topic where Dheeraj sir was also working, and there are many uh, scientists or researchers doing their job on the bionic eye. Now, bionic
Yes,
eye,
ma'am.
yes, yes, Sarah.
No, actually, we will be very grateful if you share with us your thoughts.
Yeah, so the bionic eye is basically an artificial eye. Now, the artificial eye, the research was, I think, started in 2010, 11, something. And it was at its peak around 2014, where I think even Dheeraj sir contributed something to the bionic eye. We used to talk about it, but I really don't know how far he is there. So Argus 2 is one of the tentative product which will be coming up. It was almost finalized in around 2020, and then the work stopped, maybe because of COVID. It started again in 2023, and in around starting year of 2024, that is last year, US was the first to implant some of the bionic eyes, that is Argus 2, and it almost fitted, and they have a trial undergoing. Almost 300 individuals, they are undergoing a trial where the bionic eye is fitted. But obviously, as the eyeball and its connection, none of the researchers are close to what a natural eyeball is like. There are certain limitations of this bionic eye. This was the Argus 2, I think. Argus 2 was the closest bionic eye, which the US is under trials for it. That one eyeball is going to cost almost $150,000. So that is almost 1 crore rupees, only the eyeball implant, which they are going to implant. The surgical hospital cost will be different. So it is obviously not within reach to most, to the Indians, or rather in UK also, it's not within our reach at present, because it's just in the trial period. But there are certain limitations that were found, and the limitations were that, uh, as I said, eyeball has on the images go on to the cornea and to the retina. In the retina, they are processed, they go to the brain, and then our brain knows what is, why this is called as a door, why this is light, why this is a curtain, why this is table. So it's an integrated thing. Images forming onto the cornea, from the cornea to the retina, going onto the brain, where the brain interprets and tells us that, yes, this is the image of the door. Yes, this is Syra. Yes, these are the curtains. This is the window, right? So these interpretation is done in the brain. Now, when you are going to make an eyeball, you need something called as retina. You need electrodes to send this images from the retina to the brain, right? And the brain then should interpret that. So the limitations of Argus to the bionic eye, which is almost very close, the commonest limitation is that it has some electrodes fit in that eyeball. And there are only 60 electrodes they tried. And a natural eye has 1 million electrodes, 1 million neurons. So from 60 electrodes, to reach to 1 million, still we have a long way to go. And that is the most common research or a topic of interest for most of the engineers, which they are trying their best to make a eyeball. And that is called as the bionic eye. So that is something about the latest things in the eyeball formation, or but still nobody is yet successful to make a eyeball which will be fitted. So it is just a prosthesis and not a real eyeball at present. Yes, that's my thing in the recent advances of ophthalmology. Yes, Sarah, I think I am done. And I think
Okay,
there are no
ma'am.
questions from your audience. So do you want me to speak something more, or it's already, I think it's nearing 8:30?
Yes, ma'am. Here is in India now it is 8:30.
Yeah, so
Uh,
sleeping time for most of
yes,
them.
ma'am. We have one question pop up. Yes, Kiran
Yes,
Ande, ma'am. You can continue with your question.
yes, I can hear. Carry on, please. No
Yes,
problem.
ma'am. Any question you can ask. Ma'am, you can also open your mic and you can directly communicate with our expert.
Well, on cataract surgery, my thoughts means I am doing phacoemulsification since last 10 to 12 years. And that is like the most advanced which we are doing everywhere in the world. And even India is not back. We are competitive with most of the Western countries. Well, Kiran, as far as protecting our natural eyes, yes, because you can see from the latest research that there is no such thing as a new eyeball. You cannot produce your eyeball. What we have is a greatest gift from God, and it cannot be made. So the main thing is protection of eyeball from injury is the commonest cause for losing the eyesight. So injuries, traumas, uh, I think it around 15, 20 years back, there was this Ramayan going on. And every children, they used to make that bow and arrow and they used to play with that. And that time we had many corneal injuries. So the corneal injuries are the commonest cause of losing the eyeball. Like even if your ordinary cup, if you just break that cup, breaks the handle, you cannot bring it back. You cannot make it as it is before. So similarly, the eyeball is a most delicate and complicated structure. If it's broken or it is torn or anything, you cannot make it as it was before. So one is avoid injuries. Second is avoid ultraviolet light. Ultraviolet light is the commonest cause of cataract. So these are the two things I will suggest to help to protect your eyeball. Yes, Kiran, I hope I answered your question. Well, avoid cataract surgery is something not possible because it is like aging. Like after some time, you will get one white hair after 40. Then 42, you will get two white hairs. Then around 45, you get 10 white hairs. Then around 50, you get 40% white hair. So can you prevent? Can you stop the white hair? You can just dye them and reduce, but it will come back again. So it's an aging thing. Similarly, as the whitening of the hair takes place because of age, similarly, the whitening of the lens, which is called as cataract, takes place because of age. In India, almost after 50, everybody gets a cataract. Here, the age of onset of cataract in UK is 70. So now you can just compare 50 and 70 because maybe the aging is very fast in India because of your lifestyle, because of your diet. Here, the aging is slightly delayed. Maybe again because of their diet, lifestyle, and whatever it's right. So you cannot prevent cataract. It is going to happen to everyone. That's it.
Ma'am, we have one question from Suman Kumar Chaudhary.
Yes,
Is
please.
cataract transformed from one generation to another generation?
No, no. It is not a hereditary disease. It is just a aging thing. Aging. So even I'm going to age, my children are going to age, their children are going to age. So aging is until and unless, of course, they are going to, there is some trials going on to stop the aging. If that comes out in 10 to 20, 30 years, then maybe the scene will be different. But it is not genetic, it's not hereditary, it's not transferred, it's just a thing. Yes, Apeksha. Yes, Apeksha.
No, ma'am, no question.
Okay, you said you had a.
Ma'am, we have one more question from Minakshi Getkar.
Yes,
She
carry
is
on, please.
asking about eyes checking through laser is dangerous or not?
Well, eyes checking is we do as I've told, ophthalmology is full of machines. So the ophthalmic first examination starts with vision, then we do the refraction if the vision is less, and then we do the slit lamp examination. So all these examination, we really don't use the laser lights. Laser lights used only to remove the glasses. That is, as I told you, excimer, if you want to remove your number. Now, Anjali said how to reduce your number. Right. So now reduction of number is in India, we are mostly myopic. Myopic means we have minus glasses, right? So the minus glasses, there has been a trial done during COVID. Most of our children during COVID, rather we also during COVID had mostly increased the screen time. The screen time was increased by almost 6 to 8 hours. Before, the screen time was less. So that is one of the reason which increases the number. Second, increase the outdoor activities because you can just change your children, the younger generation who is below 12 years of age. You can alter the number only in them. You cannot alter the number after a certain age. Like if want to reduce my number at 50, that's not possible. Yes, if you try, if your children or if your nephews, niece, or younger relatives who are less than 15 years, then you can reduce the screen time, increase the outdoor activities. That will definitely help in reduction of the number. There was one question of diabetic retinopathy. Can you ask it again, please? It just flashed. Saira,
Okay, ma'am. Yes, ma'am.
some diabetic retinopathy question was there.
It was asked by Dinesh Yadav.
Yeah,
How
yeah. Can
impact on eyes of diabetic patients?
the impact of eyes? Yes. As diabetes is one of the most upcoming disease now, right? It affects the nerves in the body, that is called as neuropathy. It affects the kidney, that is called as nephropathy, and it affects the retina, that is called as retinopathy. These three important structures are affected in diabetes, right? So whenever the diabetes affects the retina, it is called as diabetic retinopathy, and it's once started, it will just progress. So you're going to stop the progression of the diabetic retinopathy by doing type of lasers. Uh, there was some question, contact
Yes,
lenses
ma'am.
better than specs. Well, now contact lenses has its pros and cons. It has its advantages, it has its disadvantages. One, if the number is very high, that you cannot work without that, right? So in that cases, it's obviously contact lenses will give a better visual prognosis. They will have better stereopsis. They will have more clear vision. But if it is very less, that is, it's 1.5, then we should not use contact lenses. It can be used for cosmetic reasons. You're going for a party, use it. You're going for some function, use it. But every day, Never sleep with the contact lenses on. Never take a shower with contact lenses on, because the contact lenses will cover the cornea and it reduce the oxygen supply to the cornea. So it should be used in minimum. But yes, if you're using it, you can definitely, you have to maintain your hygiene. Put the lens in the morning, remove it in the evening, store it properly. And if it's a monthly disposable, obviously dispose that lens in a month. Do not use it continuously. And there is nothing like 24 hours contact lens. You have to remove the contact lens after 8 hours. Your cornea needs to breathe. And there was
Ma'am,
something
we have
regarding the
one
optic
more.
nerve. Yeah, there was some
One
question in
more.
optic nerve.
Yes, ma'am.
Op-
What kind of treatments are available for damaged optic nerves?
well, now, a very good question. Optic nerve is the nerve which connects the eyeball to the brain. So that is the most important connection from the eye to the brain. And that is damaged in glaucoma. It is developed in certain vitamin deficiency. It is damaged in some type of multiple sclerosis or some infections. So it is not in your hand. It can be damaged in some brain tumors also. So damage of the optic nerve is not in your hand. It is just some diseases comes and damage it. Once damaged, it can never be regenerated. We always say that a dried optic nerve is like a dried tree. A tree once dead cannot be brought alive. Whatever plant, water you give, whatever manure you give, whatever you give to the tree, once dried is dried. Similarly, optic nerve also once damaged is permanently damaged. So it should be treated immediately. If you have some vision issues, go to a person which is going to a proper ophthalmologist to get it treated as early as possible. Saira, that question was precautions of what? Can you read it to me
Yes,
again,
ma'am.
please?
Let me read it. What kind of precautions follow for reduce the eye stress developers when they are spend lot of time on screen? Any good suggestions?
Yeah. Nowadays, with you people being on screen for continuous 8 to 10 hours, the most common thing when we are looking at the screen, we forget blinking. So that is, which is very natural. You just stare at the screen and you just forget how to blink, or the blinking 20 times blinking in a minute, 20 to 22 times blinking in a minute is a very important part, which is required for the tear film to spread onto the cornea. So when you are on the screen, remind yourself to blink. One. Second, if after every 25 to 30 minutes of your screen time, when you are on a laptop or on a desktop or a mobile, after 25 to 30 minutes, just close your eyes for 1 minute. That will relax the ciliary muscle inside. Like even after you do a exercise, everybody tells you that after a 20-30 minutes exercise, you just relax, take the deep breath for 2 minutes or 3 minutes. Similarly, for eyes also, after 30 minutes of your screen time, just close your eyes. Closing your eyes will relax and help the tear film to spread over your eye for only 1 minute. That's not a big deal. That's not too much of asking. That can be done. And thirdly is avoid direct blowers, air conditioning blowers in your room or in your car to prevent the drying of the tears. That will also help to keep your eyes more lubricated and comfortable for a longer time. Yes, Sarah, there was one question for optic nerve and one was for diabetic retinopathy. Can you tell me that again,
Yes,
please?
ma'am. The first question was when optic nerves get totally damaged and eyes are not opening, then what we need to do?
No, 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 no. This is something confusion, because in optic nerve, the eyes will open definitely. The lids are open. You can see the eyeball. Eyeball visibly as normal as like it. You will not be able to make out whether this eyeball is abnormal or what. Optic nerve, it just is the eyeball, as I said, it's a nerve behind the eyeball. You cannot see the optic nerve. Only the ophthalmologist can see the optic nerve, and MRIs can see the optic nerve. You and me cannot see the optic nerve with naked eyes. So the eyeball will close and open normally. The eyeball will be seen as normally, but the optic nerve damage will be seen on either a fundoscope or a OCT examination or a MRI. So once damage, as said, it depends on the percentage of damage. If it is completely damaged, you cannot recover it. If it is, depends on the fibers. As I said, we have 1 million fibers going, nerve fibers going from the retina to the brain. So it depends out of that 1 million, how many fibers are damaged and how much vision is lost. Right? Yes. There was one more question. Can you read for me,
Yes,
please?
ma'am. What care should diabetic type 2 patient should take to prevent eye disorders?
Yes, that's again a very important thing. Diabetes, one, it should be controlled. Yeah, your blood sugars should not go up and down. They should be stable. And that stability has to be with a very good diet and the medication, if started, to be taken on time. That are the two commonest things. One, the blood sugar should not be like up, down, up, down. It should be stable. Second, monitoring of the HbA1c. That is one of the tests for blood for diabetes, which should be done so that if your blood sugar is a constant, then your retina and your nerves and your kidneys will be safe. If whatever you do, the blood sugar is going to affect the retina, and that is minimum of 5 years of diabetic will have develop diabetic retinopathy. It takes 5 years of abnormal blood sugars. That is more blood sugars, not controlled blood sugars. So that 5 years, if your blood sugars are not very good, not controlled, then you will develop a diabetic retinopathy. Till that, you have chance, you have a time to control your blood sugars. So do that, you can do it. Okay, so the lens cart provides a glass number using the AI machine technology. Well, as far as the number of glasses, number of spectacles which the AI is doing, it's not basically the AI. Maybe it is just the auto refractometer, again, a machine which is used for taking out the glass number. But I will suggest that whatever the machine takes, machines are, of course, one of the part, which that's the basic necessity nowadays for all of us. But a human touch is still very important, because even I have the most advanced phacoemulsification. If I don't hold the probe and go into the eye, the machine and the AI is not going to do that. Even the robotic surgeries, what they say, the robotic surgeries or whatever it is, the person or a human touch has to introduce that machine in a particular place and keeps on observing. So I really still do not believe AI completely. I'm sorry to say that, but you people maybe in medical field, it has not reached up to that standard. It cannot replace a human being. So it's a auto refractometer number, I think. But it's always better that you go personally for getting it checked. Yes. There
Ma'am,
was
the
some more
question
question.
added one more
Yeah.
line. The question further includes that it means that the Lenskart and all these companies are replacing eye specialist doctors.
But I have not heard of it. That is, can you do it online? Can you get your number online? Or you have to go there?
Mm, no, we personally go there. They
Yeah.
use some
Yeah.
machines to check our
Yeah,
eye.
yeah, yeah, yeah,
So the
yeah. That is possible.
question,
That is possible. It's because of the auto refractometer, the machine. But then the person has to check it. Like whatever the machine is showing, I have to put the lenses. If like Saira comes to me and the machine, like I'm not ophthalmologist, I take the machine, I take the number, and what the number if I put and ask you to read again, that will be more perfect than just taking what the machine is giving. I hope I answered your question, or if not, I
yes,
can
ma'am.
just elaborate. One more question was there. I think I missed.
Uh, No, ma'am, we answered all the queries of. Yes, ma'am. Now new question arises: why
Why
cataract
cataract?
occurs in eyes? What exactly the reason behind that?
As I said, it's an aging thing. So you are going to age. Yeah, all of our body cells age after a certain duration or for certain years of life. So there are being researches taking place that this cellular aging should be stopped, but still we are not yet achieved that. So as you are going to age, when you attain 50 years, when you become 50 years, when you become 55 years, you are going to get a cataract. So it's just a aging thing. As I told that when your hair becomes white after a certain age, similarly, the lens, which is transparent, becomes opaque. It was like glass like now, and now it becomes milk like. So if a milk like thing comes in front of your vision, that is called as cataract. It's like a curtain coming in front of your eye, which is because the clear lens, a transparent lens, becomes opaque. That is because of aging only, no other reason. Of course, there are various reasons, but aging is commonest. It can be trauma, many other reasons are there. Yes, Saira, there was one hand was there in between. I don't know where it was. I cannot see it now.
Ma'am,
Anyways,
but we don't have any questions. So, ma'am, one
okay.
question again. Why
Yes,
sometimes in cataract surgery lost the eyesight?
yes, that is one of the complication, which is very sad, but it happens. The commonest reason is infection in the eye. Now, any procedure, especially in India, we have a lot of microorganisms, and the infection rate is very high in India. So, improper sterilization of the equipments, improper sterilization of the theaters, some problem somewhere can give rise to endophthalmitis post-operative. That is an infection which takes place in the eye, in which the eye is lost, which is a rare complication, but yes, it happens. Yes, sir.
Any further questions from any participants?
I think you
Our
have crossed your time. It's almost 9:50. No. Okay.
It's 8:45, ma'am. But
Okay, no problem.
the participants are really interesting in asking their questions.
No problem. Carry on. I am interested in answering also.
Ma'am, actually, I have one question.
Yes, carry on. I was thinking you are not asking any questions since long. Yes,
Ma'am,
carry
as
on.
being a mother of two sons, today's generation have large screen time as compared to us. So nowadays there are various ads shown in TV that use this eye drop, use that eye drop so that you protect your eyes. So is it okay to use a eye drop as generally to just go through the chemist and ask some eye drop and use it
No,
to our children's eye or to us?
not at all. Don't do that. Don't do that. Because in India, we don't have control over we get everything on the without a prescription at any chemist play at any chemist. Like here UK, you cannot get anything without a prescription. So we have some bad practices in India. Do not use any drops for children, especially because children don't develop the dry eye so soon. They are active. Just make them active and increase their outdoor activities, because that will do most of the good things for your eyes and reduce the screen time. Just don't go give the mobile to them at very early age. Even if you're giving it, just reduce the screen time. Just make it maybe 1 hour in the afternoon, 1 hour in the evening. That's it. And in between, then 1 hour of playing is important. Like to outdoor playing. No drops
Okay,
will help.
ma'am.
Yes, Anjali, very good question here. Now, to reduce myopia, as I said before, there is a new drop coming up, atropine eye drops with very minimum concentration. But then that has to be done by an ophthalmologist. They do um, take the vision and check your refraction before. Then they start the atropine treatment. Then they are followed up regularly, and it is a long thing which is done. Like it will not happen only with one installation or two drop times. You put the drops and your vision is gone. Your myopia is reduced. No, it is known to reduce the myopia, but as I said, in a certain age group below 12 it will be successful. Second, the atropine has to be put for a particular duration. Third, you have to reduce the screen time. Third, increase the outdoor activities, and all these combined will definitely help to reduce the number. Well, Anjali, the name of the drop, as I said, it is a particular concentration of atropine. I cannot, it's atropine eye drops, not the regular ones. It is a very less, 0.1% or not 0.5% is used. And that it is always better to do under a guidance. Just do not do it by yourself, because that may not be really very effective.
Ma'am,
I think there were some more questions from Anjali. Did
yes,
I
ma'am.
miss?
Yes, ma'am. Yes, ma'am. There is one question. Are there any exercise for eyes?
Yeah, exercises. Yes. This is something new. I also believe in yoga, like all the our body needs to be activated. The blood circulation has to increase, and what yoga does, it just, or any exercises does, it helps your muscles and your blood circulation and your lymphatic drainage so that they don't get stagnant. If you sit continuously, obviously your muscles, your blood supply, your lymphatic drainage becomes stagnant. Similarly, for the eyeball, you have to just sit properly in a position, just do all the type of ocular movements and closure of the eye with little just massage of the eye. These are going to affect, but then again you have to just observe some videos and do it. So some muscles, like our eyeball has some muscles in the eye, like moving the right, different muscles, moving to the left, different muscles, up, different muscles, down, different muscles. So all these muscles, if you are going to activate them by doing a particular action, like if you're sitting like this on a computer, you're just going to look straight at the screen. You're not going to look like this, like this, like this. So these ocular movements, which we don't do it regularly, if you try to do it voluntarily, that may help. But that has to be done at a particular time, early morning, for maybe a couple of minutes, and see some good video for that, and then you can follow someone. I'm not an expert in that.
Okay.
The optometrist, I think in UK, the optometrist cannot prescribe the drops. It has to be ophthalmologist. But in India, there are some optometrists who can prescribe you that atropine drops. But I will still suggest that the pediatric ophthalmologist should be the best person to prescribe and see the progress of whether the drop is effective or not. If you just go and buy and put, they may not be as effective as the effect what we want. And I hope
Ma'am, we
Anjali is
have
still not
one
satisfied.
one question, ma'am, actually from participants.
Yeah.
Which surgery is best to avoid the glasses?
Yes, nowadays, like LASIK has come up. Now, the LASIK, as I told you, it's type of a laser which will remove some tissue from your cornea and then replace back the flap, which is done commonly. That is the LASIK, LASIK, excimer LASIK surgery. But one newer than that has come up, where they are not going to ablate that tissue, they're just going to put a lenticule. But it really depends on the number of the person. If you are having a number more than 2.5, then go for it. If you have less than 2.5, just avoid it.
Was last question asked by
Yes.
Dinesh Yadav. How to improve visibility without using any lens?
Okay. Visibility means you mean to say by driving, or first of all, you have to just check your vision. That you can do with any opticians or any. If your vision is 6 by 6, that is 20/20, where what is used here. So if that is your vision, that you need not do anything. But if your vision is slightly less, obviously you will need to get some spectacles, some correction glasses, and that's not necessary that you use it 24 hours. If there are less, that like people don't like to use glasses continuously. So if it is somewhere -1.75, zero point 0.5, 1.25, just use it while driving and watching telly. Otherwise, while your desktop computers, you don't need, you all are young people, so you don't need any glasses for that. Driving is, yes, you require most clarity during that.
Okay.
Eh,
Ma'am.
Yes, what kind of, if I ask to
What
them
kind of
about the,
right question if I
okay,
want to ask to them about the drop to doctor?
yeah, it is called as atropine drops. Atropine in a lower concentration, which is used to correct myopia. That is the, so atropine is used to dilate the pupil. So that the concentration of that is 1%. That concentration you cannot use for your children for correction of myopia, because that will dilate the pupil, vision will go down. So the concentration which is available is not 0.01 and not 0.05. I think that is the minimum concentration, where it just relaxes the ciliary muscle and helps in reduction of myopia. Okay. Yes, Sarah.
Yes, ma'am. Now there is no further questions from participants. Shall we
Yeah.
conclude the session, ma'am?
Yes, definitely.
Okay. Thank you, ma'am, for sharing your expertise with us. Your lecture was highly informative and helpful. Our participants are also very interested in asking the questions and they are satisfied. It was really very incredible and enlightening to us. Thank you, ma'am.
Okay. Just say hi to Dheeraj sir. He was the main person because of which, because of him, I'm here. So I will share my presentation. You can just put it up if you want. Okay.
Okay, ma'am. Thank you, ma'am.
Okay. Thank you. Thank you for giving me this opportunity. And good night, all of you. Thank you.
With these, we come to the end of our second session of third day. Thank you all for your participations. I request all the participants please fill the feedback form for day 3, session 5 and session 6. Your participation makes our session successful. Thank you all and good night. Please, before leaving, fill the feedback form.